So in your own words, what are the definitions of burnout and moral injury? What are the similarities and what distinguishes moral injury from burnout?
I can go first.
Okay.
So I came up with like these definitions. So burnout, I said it's like a feeling of like being desensitized and like just overall numbness and apathy, and as a result of like repeated like endured stress. So like I feel like we're probably all kind of feeling that a little bit. Just like over time, it just kind of like eats at you until you like don't feel like yourself kind of. So that was my thought on burnout. Moral injury, I put a disruption in one's morals as a result of a like witnessed act. So like you saw something happen that like you don't agree with, but for like whatever reason you just like let it slide, and like that's an injury to like your morals, like your personally held beliefs. Um, they can be very similar, but I think like burnout is something that like, in my opinion, is probably more common. I think moral injury is like a little more like less common, but probably like easier to like avoid, I would think. But I don't really have a whole lot of experience with moral injury. I haven't experienced it a ton throughout my clinicals, so I don't know.
I can go next. I agree with everything you said. My definitions for burnout were inability to perform at one's best due to mental exhaustion and physical exhaustion. So shortcuts are often taken in order to preserve what energy you have left. In terms of moral injury, I said shortcuts are also taken due to requests or requirements made at a higher level from bosses or the place that you work in order to perform. So, like, that's asking too much of somebody in order to perform their job with no moral issues. And as far as similarities go, I said they can both cause someone to feel exhausted, take shortcuts, and then patients are often receiving less than ideal care that they should be receiving because of these expectations.
I can go. I said burnout is very similar to what you said. It's a state of mental and physical exhaustion or like not feeling fulfilled or good enough in your job. And then moral injury is more of like a healthcare system and the culture being at fault rather than individual. And I also said the outcomes are very similar, but regardless of the reason the clinicians are feeling like they're not able to carry out their job and they're just physically and emotionally drained by the end, and it's hard to have like that work-life balance. But like distinguishing the two of them, I felt like burnout is more of an individual problem, whereas moral injury is more healthcare problem, system problem.
Thanks. I can go. I said burnout is a state of exhaustion caused by chronic factors, requires increased demand from a person, resulting in decreased energy. Moral injury to me is more psychological distress caused by experiencing situations that go against your personal moral beliefs. For the similarities, though, I think they both can cause emotional exhaustion and diminish your sense of purpose while resulting in decreased motivation. And I think they're both common in healthcare workers. How to distinguish, though, I think examining your underlying cause of the emotion and determining if the feelings were caused by having to manage too much. That'll tell you if it's burnout or if it's associated with conflict within the person, which would lead you to moral injury as the cause.
Yeah, I mean, mainly agree with everything that's been said, but more so like trying to differentiate the two. I feel like burnout, continued moral injury can lead to more burnout. So like a specific example that I feel like specifically with outpatient that I saw, or I am seeing, I'm an outpatient now, is like patients have like additional questions and like ideas that they want to talk about with like a PT, but like just due to like how busy the clinic is, you can't sit there and talk with. So you're essentially like sacrificing what the patient might want to talk about or need to go grab your next patient because you kind of don't have the time. And I feel like that goes against, at least for me, like I would want to help the patient as much as I can, and you just really don't have that option. And you know, a lot of that piling on top of each other leads to, in my opinion, more burnout, where like you kind of lose that like desire to help people and passion to like give the patients your undivided attention and effort that you would like to, but you just can't because of kind of like Hannah said, the healthcare system, how it's set up with the amount of patients we have to see and things like that, so.
Do you relate to experiencing feelings of burnout and or moral injury as a student physical therapist, and if so, how?
I can start. So for example, my first clinical was at the hospital, so I was in acute care, and they required productivity checks weekly. So my CI and a lot of other therapists themselves felt maybe some moral injury in the environment just because they were expected to get in and out of people's rooms just in order to check off that patient for the day, just because they had to meet those productivity requirements. And at my second clinical and outpatient, the hours were so long that I could feel myself getting burnt out if I continued that way. So I noticed how much more engaged I was and like able to create a great plan of care when I wasn't exhausted. But it didn't feel right to me knowing that some people had a better version of myself that wasn't exhausted compared to other people got me maybe at the end of the day or end of the week, and I was like maybe struggling like mentally to create the best plan of care that they deserve. I also feel like sometimes I wasn't able to plan for the session as much as I would like to due to being on a timeline to complete the documentation because there's so many people you're seeing throughout that week, so.
Yeah, I agree with what you said there about the burnout, and like, I was able to like do well with like, while I was at the clinic, in outpatient specifically for burnout, but like, it was once I got home, like, I was so just like, I was a zombie. And like that, it was affecting like my work-life balance. I just felt like I was giving everything I had while I was in the clinic, and I got home, I just like had nothing left to get, and like I would just sit on the couch for 2 hours and go to sleep. Like that's all I did. So that really affected me specifically with outpatient, but then like moral injury in like inpatient rehab on like eval, you have to like score every patient on like the same like 12 or whatever. Like certain like things like a sit to stand transfer, like a car transfer, like how they do walking. You're supposed to do it every like evaluation. But like we get a lot of pressure from like the, powers that be above us to score people lower on eval, even if like maybe they really weren't lower, because they want them to have like, to show like the best like improvement possible. Because if they do that, they're gonna get more money. So it's like kind of like a moral injury there because I think this person really was probably like a menicist, but like, you get emails, well, are you sure they were a menicist or they may be a monicist because such and such, so it's like, it just kind of goes against like what, I believe, but it's just the system, so.
Yeah, I would kind of similar with the outpatient realm, like. For me, I feel like. Working 10-hour days at my outpatient clinic now, like. You're seeing so many patients, and for me, it's like hard to like turn my brain off when I'm done. So like I'm eating my lunch as fast as possible so I can prep for patients in the afternoon and finish my notes from the morning. And then like when I get home, all I can think about is like, okay, this is who I'm seeing tomorrow, like what exercises can I do with them? Like it's hard for me to like turn it off when I get home. So like I'm constantly just engaged with like outpatient PT, and it kind of I've noticed 6 weeks into this clinical, like it's as I'm seeing more and more patients and more caseload, like it's kind of feeling like burnout to me. But
Yeah, mine's very similar to yours, like my outpatient that I'm in right now, we see 12 patients back to back every day, and you come in at 7:30 and you don't leave until 5:30 or 6, so they're just really long days, and then as a student, you're still not like, you don't feel like you're efficient enough, so you want to prepare the day before, so like I'm spending an hour to hour and a half to prepare for my patients the next day. So then you get home late, you prepare, and then you're right back to doing the same thing, which is a lot.
Yeah.
But like where I was in the SNF in my second rotation, we worked from 8 to 3. And then you went home, you didn't think about anything the next day or that night. Like you had a really good work-life balance, which was really nice. Like I never took anything home.
Yeah, I agree with everything that you guys have said. I just don't think I realized how burnt out I was during my first clinical because it was in an area that didn't have great patient compliance. They were 30-minute sessions, and by the end, they started introducing dovetailing. So I had a patient coming every 15 minutes. It was also unfortunate because a lot of them didn't come back, so I would spend all this time chart reviewing, evaling, and like getting ready to come up with their plan for the next session, and then I just would never see them again. It also kind of stunk because there was a lot of PTAs there, so most of my patients that did return went to a PTA, and I was stuck in a closed room evaling all day.
Evaluating discharges and stuff.
And no shows, and I would chart review for my entire day, and then half of them wouldn't show up.
That's the worst.
Yeah, so by the end of the day, I was exhausted, and I don't think I realized that until I went to do like schoolwork for my electives, and I just wouldn't have anything left to give to them. And I don't think like I put as much effort into them as I felt like I could now that I'm at a different outpatient clinic and we have better compliance, 45-minute sessions, no dovetailing, less pressure for productivity. I'm just enjoying it a lot more, and looking back on it, it's like eye-opening of how burnt out I was, so that's my experience with it.
Have you observed colleagues in the clinic demonstrating and or sharing feelings of burnout and or moral injury? List specific examples.
Yeah, I touched on it earlier, but in acute care, I think moral injury was very present at the hospital because of the productivity requirements each week. And also daily meetings in the morning with like the president or higher ups of that whole hospital, making sure that there's beds being available, and like the turnover rate was like just very high because essentially they're trying to make money and keep things moving. So it seemed like a lot of people cared more about checking the patients off their list compared to maybe quality of care that could have been given. They did seem to address those feelings of burnout, however, by rotating their assigned wings every day or every week. So when you would come in for the day, the whiteboard would tell you what floors and rooms you were taking, and they tried to rotate, like whether you were in the ICU, you had like a 4-week rotation there, versus when you're not in the ICU, you go from like the step down unit to like the MCU and whatnot. So they kind of rotate like responsibility just so they're not overworking one therapist over another. I also feel like there's some moral injury in my current rotation in pediatrics outpatient due to insurance requirements, just because a lot of clients are hindered from the best quality of care because they're not allowed, some insurances are not allowed, they don't allow therapy to bill more than a certain units in a day. So it limits our time with that specific client just because of their insurance versus what they actually need. So if a patient needs like an hour and a half with us, but we can only bill 3 units or 4 units, especially because we're co-treating, that hinders what we actually want to do with them to make them reach their goals. And also with equipment, a lot of these kids are growing drastically a lot of times and equipment breaks. However, it's very hard to get equipment more than once a year. So that's also something that I feel like is a moral injury that you see because you want to offer them the best solution, but they can't maybe have it because of insurance, so.
Yeah, I think, and like I've been in acute care, outpatient and inpatient like rehab, and all 3 settings, it's just like, to some like degree, we're just playing like the insurance game. Like, we just gotta play the game and like, just kind of work within it, and I think that has led to a lot of burnout and also moral injury for like every clinician that I've been around, just because it's exhausting. Like, you're trying to give your best to this patient, but you're being held back because of whatever insurance like deal that you have going on, and you have to just like do your best to like play within that, and that, I mean, that's draining, like when you're just trying to give quality care and give your best to every patient, but for whatever reason you're not able to. So I've noticed that in every single like setting I've been in, so that's kind of tough to like take, but.
I would say like along the lines of specific examples of burnout. I didn't really see it in home health at all because home health has such a nice work-life balance. So like, I feel like that avoids that. Like approaching burnout, but like in outpatient or even in acute care, like. Just like the attitudes of therapists, like ones that seems like they had been there longer, you could tell. Had more of a negative outlook, had less like creativity with interventions, seemed like they were less passionate about therapy and helping people. And I think that's really just a testament to like the burnout itself and how,
The quality of care goes down.
yeah, like how that can affect you and in turn affect your patients, so.
Yeah, I dealt with something similar at my first site. One thing that came to mind was an older PTA that was pretty close to retirement, and she would come in every day telling me how she just wanted to be at home swimming in her pool. And like, I don't blame her. Every patient that I did a reassessment on wanted to see her again, wanted to only be scheduled with her because she was the best PTA we had. And I feel like when you play that game for all those years and like understand the process of it all, especially in the setting that I was in where it's really low compliance, like I feel like all of her success was more challenging for her to appreciate, so she never really wanted to be there. She didn't really want to see anyone work with anyone, but everyone that was with her valued her care and thought she was just the best at really everything. And then a lot of the time with younger PTs, I've noticed at all of my sites that they just want to work less hours. They don't want to be full-time. They want to do something on at least one day a week, something different, take more vacations. I think that's really valid and it's important to take time for yourself, especially because the job can be really chaotic. I think especially in outpatient, a lot of PTs have trouble recognizing the changes that they make every day in people's lives. Because then when I see those patients, for like the first time, I really recognize how much they appreciate working with them. So it's just my thought.
I feel like I've seen more moral injury in my outpatient clinicals. One thing is insurance companies, like you mentioned before, it's hard to get visits approved, so then it prolongs their rehab process and prolongs their care, especially if they just had surgery and they're not approved, then it just pushes them back even farther, which puts more stress on the therapist. And then another thing is documentation. Like for the clinic I'm at right now, we have to do online paperwork, and then we also have to do like write out our exercises on a different form. So like doing that, typing in the computer, all while you're doing, you have 40 minutes with the patient, you still want to develop patient rapport. So I think it's just a lot to keep up with. So, and with the clinic I'm at right now, they can't take anything home with them, so they have to finish all their notes that same day, which is also very stressful.
Yeah, that's a lot.
Yeah.
Also, just like touching on all those points too, I feel like you see a lot of, at least in my experience, like trying to get the most units out of your time. So like you try and, make it to 8 minutes rather than 7 minutes, so you get that extra unit. But at my outpatient ortho rotation, you kind of saw the other side of it as we were keeping patients upwards of 3 hours if that's how long they needed. Because the owner of our clinic and the PTs there cared about the quality of care. They wanted them to get better. They cared about like the patient and how they were doing. But we would only charge maybe 5 units. So we were undercharging, underbilling. So that was like a daily thing with almost every patient that you saw. And it comes at a cost, I'm sure, to, the PTs and the owner of the clinic, but he cared about that quality of care. So I feel like that's another aspect of burnout, but for good reason. But I thought it was interesting, different side of things.
Has anyone observed their colleagues using specific strategies to prevent or address feelings of burnout?
I think just people being as efficient as possible with their documentation, trying to save their work-life balance, like.
Yeah.
Documenting through lunch or like documenting while you're eating, like it sucks, but like. It does save you because you get to go home and enjoy your life outside of work, so.
Yeah.
That's probably the biggest one I can think of.
I also think I feel like therapists strongly advocate for their patients, like they take the time to try to get more visits and do everything they can to prolong it, so.
For this one, I kind of had a different example for it of on 2 of my rotations, my first one and the one that we're currently on. my CIs took vacations.
That's where I was gonna
And that was really daunting when they told me that the first week. But I understand, they both seem to try and limit their time away from the clinic throughout the rest of the year. They both told me that it was like once in a lifetime trips, and they truly seemed to be. So I can understand how it's kind of a reset for them, even when it's not convenient timing. I just feel like it's necessary, and they both recognize those feelings, and they took the action to give themselves some time away, which I think they deserved it based on how hard they worked. Yeah, so it was a good reminder that sometimes choosing to do something for yourself is good.
Yeah, all three of my clinics, my CIs take like over a week vacation, and like you said, I don't blame them, like, it's very necessary in my opinion, I feel like. Not just with vacations, but just like talking about like weekend plans and trying to set things up outside of the clinic with friends and family, like. Even if it's just taking a day of PTO, like, I think that goes a long way with burnout, so.
Yeah, in my experience in my outpatient ortho clinic, most days there would be a 2-hour lunch break, sometimes less, but whether everybody liked it or not, that's what, the boss gave them. And most people took advantage of getting a workout in and getting a lunch in and doing whatever they needed to do. So I think in that sense, it may have helped with those feelings of burnout and like being able to maybe check off a workout from your to-do list for that day. However, not everybody, maybe some people would want to go home 2 hours earlier. But I think for some people it worked in addressing those feelings.
Identify examples of how you observed a system enhancing the quality of care by improving patient experience.
I can say, so. One thing like for me that was noticeable when I was in home health, like my CI would. Occasionally like just give the patient autonomy, like if she had her schedule pretty open, she would pretty much allow them to sort of select when they. Like want to see the PT, which like only worked with a few patients, but like that really already started to build rapport instead of like. Telling the patient I'm gonna be there at 8:30, like tomorrow morning. So I think that kind of went a long way. And then specifically like in my outpatient rotation, like all of our evals, we ask at the end, like a patient stated goal. Typically, it's like returning to, a sport or some sort of activity, like a hobby. And I feel like that sort of also goes a long way with like giving them more sense of direction with like, okay, this is why I'm at therapy, stuff like that. So.
For me, currently in like inpatient rehab, we do like teams meetings every week where it's like the entire PT, the entire OT, like speech staff, doctor, whoever, and like nursing is all in on a meeting, and we go over like every single patient in the hospital and like just communicate, and everyone kind of gives like their update on how they're doing. And I think that's just like really helpful, just making sure that everyone's on the same page from every discipline that's in the hospital. And I think that really helps with like the patient experience, helping them like, get home faster and get to their next stop just faster.
Yeah. Sorry.
Go for it.
Okay. At every site that I've been at, there have been patient satisfaction surveys, and they were reviewed at monthly staff meetings, and any areas of growth were talked about, and like a plan was figured out for how to address them. They also did in-services, whether it was students presenting or staff even presented. And that was to better patient care in various areas that maybe they didn't have such a good understanding of yet. And at my first site, I actually saw them start up a journal club. So they would read the recent research studies, discuss the findings, and then they would talk about how to implement these findings into their practice at the clinic, which I thought was really interesting.
I said, having consistent patient therapist pairing, to ensure patient buy-in, so like you develop that therapeutic relationship with them and you work with them every single time, so it kind of helps you get closer with them almost and take an interest in their lives, which is helpful. And then also including them in their goals. We ask the same question, like what their specific goals are for therapy. And that also helps their buy-in.
I mentioned it earlier, but in my outpatient ortho rotation, like patients could be there as long as they needed. So a lot of them were pretty independent too. They knew what they came in to do and their exercises and stuff. So they would be there for 2 or 3 hours if they needed to take that amount of time. So I think that helped I saw a lot of therapeutic lines there with patients knowing that we cared because they could be there as long as they needed to, come whenever. We're always there to help. Just so that they receive the best quality of care. And we also did in-services at all of my rotations as well, just to help educate like the therapist on some weird case maybe they haven't seen before, like I did nutcracker syndrome, nobody really knew what that was, but now if they get a nutcracker syndrome case in the clinic, they'll be prepared, so.
What about for improving population health?
Go first. So both my outpatient sites have been connected to a gym. So when they're done with PT, they are able to get like, I think it was a free 6 weeks at my first one and then a reduced cost membership at my current one. So they can continue exercising, and they also gave them a lot of information on programs at the gym, including chair yoga, silver sneakers, and even like the personal trainer information so that they can continue with their exercises.
My outpatient clinic was the same way. They'd give them like a free month pass to the gym, which I thought was really cool and a good idea. Also in outpatient, I noticed like on Epic, they had like a social determinants of health, like little like tab.
Mhm.
And it showed like red areas were like areas of like concern, or like the green areas were like the areas like, that they were doing fine in. But I thought it was really interesting that Epic had it like specifically pointed out. So like you could address like smoking cessation if you like wanted to with the patient. So I thought that was really interesting.
I said at our clinic, we really emphasize the importance of home exercise plans. So each time they come in, it's usually like once a week, and we'll prescribe them new exercises, so they're not coming in for as many visits. And then also with our specific patient population, we see a lot of post-op, so having those protocols that are specific to each surgeon, I feel like that makes consistent care across each patient and makes the care efficient as well.
Yeah, kind of along your point for the next point of like reducing costs. When we do like discharges with like our patients, that have been there for at least a few visits, we like to give them like, in my outpatient experience, like some additional exercise, like progressions for their HEP, to hopefully avoid like, give them something to continue to work on to avoid maybe needing another PT session in the future, or, potential like a personal trainer, some like gives them like exercises that they can continue to work on outside of therapy.
In my outpatient ortho rotation, everybody had to sign up for the app. And in the app at that clinic, it was a private practice. It had every single exercise that they could ever prescribe to you and more. So the stuff that they were doing for their rehab in the clinic was prescribed on their HEP, which they could go to at any time to do at home, which we also encouraged a lot. However, they could also access any of the other stuff through that app from anywhere if they had it on their phone. They could also purchase equipment at our clinic as well, which was typically encouraged. If whatever you're using in the clinic, take it home so you can do your HEP, which obviously like being conscious of cost and spending and stuff. But at our clinic, nobody really seemed to have like an issue with it. They wanted to do that and help at home. Yeah.
Yeah, for reducing costs, I also said like the home exercise plans, and then in the SNF, they were very efficient with the length of stay. So they were only allowed to stay between 2 to 3 weeks. And they received speech, OT, and PT every day. So, and they co-treated a lot, which improved the efficiency.
In my current like inpatient rehab, we do like fall prevention groups like once a week, where we just do like education and give people like tips and tricks on how to avoid falls. But then if a fall does happen, like how do you like recover from the fall and like try to get back up without having to call like somebody in, assuming they're not seriously injured. Of course, but I think that was just like pretty cool because it can help like reduce like calls to paramedics or like these people going out to the hospital or whatever, and just
To the last question.
Yep.
So I thought it was fun, like we did like a fun thing in my outpatient setting where to address like burnout. It was sort of just like a colleague. Everybody, like all the PTs and the PTAs there pretty much just set it up themselves, but just did like a random potluck like on a Wednesday. And it was just like the best thing ever, like it just, you could tell like everybody that day and really the rest of that week,
It was going for it.
yeah, it was like kind of like a breath of fresh air, like,
Yeah.
okay, we have something else to like look forward to other than 10 patients today. So,
You know, my site now did, like, they do that every month, so we're coming up on the April one and I'm really excited. And they also, at this site, they don't overlap patients at all, so there's no dovetailing. And I feel like that helps reduce the burnout in providers. And during my inpatient rotation, the sessions were an hour long and it was designed that way to give them time to document in between, so they didn't have a long list of patients to document for, which I thought was really nice. And then at my current site, I also think it's nice that mentors are provided for the new hires. And then they don't start them at like a full schedule, they start them at 50% of a schedule to get them adjusted to the clinic. And they always have someone to reach out to if they need help with anything.
Mine was kind of the same. We, in a SNF setting, like everybody would always eat lunch together, all 3 disciplines, so like it was kind of a de-stressor moment. And then they also did staff lunches. When I was there, they kind of did it like once a week, but I think they do it once a week.
Same thing, food. My current outpatient peds, they, I think, do potlucks every month. But I think any excuse to celebrate, they're doing one. So we actually have one next week, and then I think we're gonna do another one once all the students leave, because there's quite a few. So they look forward to that all the time, and then also sometimes during the week, they order coffee for everybody in the office, so. I mean, you have to pay for your own coffee, but like getting coffee from outside bringing it in. But I think that also like makes their days better.
Good work, guys.
yeah,
Do I just have to hit?
Stop recording and
Where's stop recording?
what if we didn't record the whole thing?
oh,
Do I just hit end or what?
No, cameras.
I'll let you do that.
did you change your site for opening day?